Thank you very much, James. Thank you very much to BASEM for including me in this, and UKDIS as well. Forum I personally find very helpful. I learn a lot from it, so thank you for that. So James asked me to talk about a few topics around the shoulder and when to operate, and I think that could be a very easy answer because it's very easy to offer a patient an operation as a surgeon. What's very difficult is to know if and when to operate, and we often have surgeons saying, worried about that operation, the fixation wasn't quite as good as I liked it. I've never heard Mike say that. And that really is something that shouldn't worry you, because that's just a technical procedure that you should walk away from every operation saying, absolutely, that's 100% right. What does worry me more is whether I've made the right decision on that patient to operate or not. That's quite a nose. We'll run through some of that together, and hopefully we'll brainstorm some of that together, and please do interact with us. So I'm from Wrightington, and I feel very fortunate. We're the largest upper limb unit in the UK, and this is my Wrightington family. We play together and we work together, so I'm very fortunate in that respect. And also we share a lot of complex cases together, so a lot of my decision making is made easier because I've got these colleagues to bounce ideas off. Now when we're thinking about decision making, this is one of the things I teach our fellows, is when you make a decision, and there's a lot of research on decision making, is what you use to make that decision. And there's three things that you use. It doesn't matter what the decision is. So there's normative, which is what the research tells you, what the data shows you, what the evidence base is. We always talk about evidence-based medicine, so that should be important. And then there's cognitives, the environmental things. So the environment you're in, how that affects your decision making at the time. And then psychological. And the strongest factor in psychological is your individual gain from making that decision, okay? But it's also your values and your preferences in life that'll make that decision for you. Which one do you think is the most important or comes up the most in making that decision? Absolutely. 60% of any decision, and they've done this in medical decision making, all sorts of decision making, 60% of any decision you make is psychological. So as much as we think we might be doing evidence-based medicine, actually you're not. So as much as we like to think that. So what I try to do, and I tell my fellows to do, is once you've made a decision, then before you tell the patient or the GP or whatever that decision is, ask yourself first, why have I made that decision? And it's amazing how you will then change your mind in making that decision. So I'll just run through a little bit of anatomy. I know you all know this anatomy well, but you know your muscles of the shoulder, and then you've got your deep muscles, which is your rotator cuff, which are your stabilizing muscles. You have your big movers, your stabilizing muscles, and then very importantly you have your glenohumeral ligaments, which is just foldings of the lining of the capsule of the joint, which give you some stability, a static stability to the joint, and it is a very mobile structure. Under that you have the labrum, which I always describe as like a washer to the glenoid, adds a little bit of stability to the joint. When you hear people talking about the labrum or you read reports, the labrum is anterior, posterior, inferior. The European standard is that 3 o'clock is always anterior and 9 o'clock is always posterior. It's always better just to use anterior, inferior, or posterior, inferior, but sometimes you've got to be careful because some people use 9 o'clock for the left at the front and 3 o'clock for the right at the front. The standard should be 3 at the front and 9 at the back. Bankart tears are between 3 and 6. Reverse Bankart to posterior labrals are posterior between 12 and 6, and then slap tears between 12 and 3. Between 12 and 3 o'clock, the labrum is not well attached. So a detachment in that area is unlikely to be a tear of the labrum. The common injuries you're going to see, and we'll talk about, is the anterior labrum, the Bankart tears. You also get bony injuries here, so this is the bony Bankart. Posteriorly, posterior labral tears, and superiorly slap tears, rotator cuff tears. Not that common in young athletes, but we'll cover that. And then tears of the capsule, the Hegel tears. So let's run through the first case. So this is a 17-year-old male rugby centre for school. He's the captain of the school, and they're a premiership feeder team. He had his first shoulder dislocation at tackle, is mid-season, relocated in hospital, presents 1 week, no pain on returning, and he's starting to return to training now, and he sees you about a week later. So a little bit of facts, you probably all heard this, but just to remind you, a lot of studies show that for this particular athlete, rugby player, 17 years of age, traumatic confirmed dislocation, the recurrence rate is well over 70%, so in some studies almost 100% for his recurrence rate for this particular group. So what are you going to do, guys? Okay, get your hands up now. Who's going to do x-rays? Okay, good, good. I'm worried about the ones that didn't put their hands up. Okay, ultrasound scan. Okay, MRI. Okay, well it's over a week now. We do an MRI. MR arthrogram. Okay. Would you just let him return to play as comfortable? Anyone? You can be honest. I mean, what we do in reality, would you do an well, not would you do, would you get someone to do an arthroscopy? Okay, one, or you might do it. Okay, so let's run through that. So this is his MR arthrogram, because the majority of you said you wanted that. And that shows an Elpser lesion. So what that is that there's a Bankart tear, which is then flipped around the corner. Okay, and what we know is that a recurrence rate of an Elpser is much, much higher than an undisplaced Bankart tear. So he's got an Elpser lesion, and he's got probably a small heel sac lesion at the back there. Okay, so you've got your MR arthrogram. What are you going to do? Who's going to let him return to play as comfortable? Nobody. Arthroscopic stabilization. We'll just say surgery, it doesn't matter if you... Okay, okay, so who would say surgery again? Whether it's arthroscopic or Latarjet. This talks for surgeons also. Okay, right. Any other form of surgery? There are a lot of abstinences. Okay, so let's look at a little bit more evidence then. So here is quite a nice big study done on contact athletes in the US, and they looked at this particular group of patients, okay, and they found that most of the athletes were able to return to their sport and complete their seasons after an episode of shoulder instability or dislocation. Only 30% had one episode of instability during the season. It wasn't true dislocation, so they had an episode of instability during the season. So that goes a little bit against what you've always been told. Then another study, again a very good group, also on contact athletes, found that for first-time dislocations or recurrent dislocations, so we're always told you must operate on them after their first dislocation. Again, that they found that there was no difference when comparing first-time surgery for first-time or recurrent dislocations. So now we've got to think about this guy again. So what were we treating there? We were treating the pathology, weren't we? We were treating the Elpser lesion, which is what we're always taught to do. But there's a number of factors. The patient doesn't care whether it's an Elpser or a Bankart. They want to care because at this stage, he's mid-season, he's captain of the team, this is his chance to get a premiership contract. So you say to him your recurrence rate is over 70%. That doesn't mean anything to him. But if you take into account the fact that actually the majority of them will probably get back and finish the season, with only 37% of them having episodes of instability but still managing through the season, he should have that information as well. Plus the fact that even if he has surgery later, the outcomes, as long as you do the right surgery, that's if you do the right surgery for him, the outcomes are going to be the same. So we don't just treat the pathology. So I think in the decision making, you got to think about the pathology, the patient, and the pressures. So the pathology is something that helps you in your decision making. And one of the things I found useful is, particularly with the pathology, is to think about major and minor lesions. So we know the recurrence rate if you've had a bony Bankart, an Elpser lesion, a full thickness cuff tear, or a Hagel tear is much higher. Whereas if the same guy had an undisplaced labral tear and a partial cuff tear with a small heel sacs lesion, his recurrence rate is much lower. So we could say to him, okay, look, you've got a small Elpser, you're at a slightly higher risk, but if you've not got that, if you've got some of these, actually your risk is probably a bit lower. But they've got to know what the risk is, and they've got to make that decision. So my approach is really early surgery for those who have large structural lesions. If they're late in the season with a smaller lesion, tend to think about surgery, so they've got time to rehabilitate back for that next season. And the key thing is if they're unable to return. So that was the other thing with him, is that he was getting back at a week to training. So if he's not coping, he's not getting back, he's going to be off for weeks and weeks, then you need to think about surgery, even if it's a smaller lesion. And those were rehab and return of the minor lesions, and those that are in earlier in the season. Any questions or comments or criticisms on that case? Dislocations. Yep,
if his X-ray is normal,
yeah,
and a week down the line he's pain-free, if you're made the decision that you're probably going to let him go back,
yeah,
there's no point in doing MR arthrograms or anything else?
Well, again, their environment, I think, is key, because how would that influence your decision and your discussion with him? That's the big question. So if you feel that will influence your decision and discussion with him, then yeah. So my opinion would be, I would want it because we can have that prognostication discussion. But I think it's perfectly reasonable for you to say, well, actually maybe better, we know there's no bony injury. It's perfectly reasonable to say, look, and this is what was done 10, 15 years ago. Let's see how you get on over the next couple of weeks, and then we'll get a scan and investigate. I think that's reasonable.
Is he likely to be pain-free if he's got a significant problem?
Well, that's a good question, but it's amazing because having done this now for a few years, grey hairs like yourself, you know, I've seen guys play through their career with huge, big, bony glenoid lesions and things that they just shouldn't be playing rugby with. So we've got to be careful about, and that's what I'm going to with only the other ones, about how you interpret these scans. So sometimes you're right, maybe if clinically they're doing really well, very quickly, you know, should you get a scan? Because that may influence, once they see and his family sees, oh, there's a tear, you're pushed into a position where that's got to be treated. Yeah, good point.
MRI rather than MRA 1 week downstream.
Yeah, okay. Definitely MRA. It depends what the question is. So with this guy, if you're questioning a labral injury, okay, which it is, then generally 24 hours would be my cutoff. If you're going to do, for an MRI, if you're going to do an MRI after 24 hours, the sensible approach is the radiologist do an ultrasound scan to see if there's a hemarthrosis, and if there's a hemarthrosis, you can get away with an plain MR. If there isn't, better an MR arthrogram, because what you're relying on is fluid seeping in to those crevices of the tears.
Even with 3T scanning?
Yep, there's no evidence that, and we're just trying to get a study going comparing MR arthrogram versus 3T MRI. I mean, I know in fact there is a lot of research all from one unit showing. Is it your unit?
No, it's not us.
Oh, okay. Yeah, that's the thing. So yeah, I think that study really needs to be done. But the problem with even with a 3T MRI, if there isn't fluid, it's not going to run in those crevices and open up any small tears, and that's what you want, that mechanical effect. So sometimes even an MR arthrogram, where you see all the extravasation of the fluid around the joint and only a tiny little bit in the joint, that's going to be very different to one where they've actually filled the joint with 20 mils. So yeah. I'll move on to the next one. So this is something you always see, AC joints. Okay, so here we've got professional footballer. He fell in a match, pain and limited movement, and it's 4 weeks before the World Cup, and he's in the squad. Okay, that's his AC joint dislocation. Okay, right. So here we go. This is the traditional facts that we're told, is that if you have a complete AC joint dislocation like that, which would be a grade 5, then an operation is used to treat patients with a 4 and 5. That's the standard treatment. Okay, so what are you going to do? Who's going to get him off for surgical repair? Now you're onto the game now, aren't you? Good, thank you. And who will rehab and return him and try and get him to the World Cup? Okay. It's not like that when I give this to surgeons. Okay, so what we base that on is Rockwood classification, which was developed as this X-ray classification, and all the evidence here, which I'll show you here, if you look at the article, it comes from 3 articles. The one was Rockwood's book, and the other 2 were case studies, and that's what we base all that evidence on. So be careful when you talk about evidence-based. What is the evidence-based? So a couple of articles, we looked at the reliability of the classification, and it's completely unreliable. And even better than that, these guys in Korea looked at the reliability using X-ray and CT scans and found that it's completely unreliable. So the classification system is unreliable to make your clinical decisions on. So the only advantage to operative intervention borne out by the literature is you get a slightly better anatomical reduction. Also, there's no correlation between the quality of the reduction and the clinical outcome. So operative or non-operative, I think the key also is when. Okay, when to operate and when not to operate. So my approach generally is when the patient demands it. It's an on-demand operation. And depends on their work demands, society demands, which is very strong at the moment, and also tend to go more for surgery for an overhead athlete or an overhead worker. They'll tend to struggle more. So, you know, plasterers or builders, not the grade. So generally with an AC joint dislocation, my standard approach is if you see them at less than a week, don't worry, don't fuss, review them again at about 3 weeks, see how they're getting on. And when in between the 3 weeks, get them off for good rehab. And what must you rehab? Anyone? The scapula. It's a scapular injury. AC joint dislocations are scapular injuries. Scapula is driven down. So rehab the scapula. Review them at 3 weeks. If they're coping and they're managing, review again at 3 months. Okay. If at 3 weeks they're not coping, they're not managing, discuss the option of surgery with them and maybe go for that. Again, if you review them at 3 months and they're not coping, they're not managing, discuss the option of surgery with them at that stage. Again, in between the 3 weeks and 3 months, you don't do nothing. Scapular rehab, and return to play as comfortable. In terms of surgery, there are over 100 different ways of doing this sort of surgery, and overall there's a 20% failure rate of all these operations. And it's one operation that I changed about 7 times in my first 7 years as a consultant. And I was always looking for the holy grail. For me it was something, because I'd been at Wrightington, do a lot of revisions of these procedures, so it's something I could use for revisions, be very strong for athletes, be anatomical to restore all the anatomical aspects of the AC joint, and avoid a donor side morbidity, because the best technique I found was hamstrings originally. And now I came across this from France, the LARS ligament, and we've been using it since 2006 now. We modify it for athletes by doing a double throw to improve the horizontal stability. This is a rugby player 3 weeks post-op, so this is the only technique where they can actually start moving straight away because it's so strong. So they can start, full active movement as comfortable straight away post-operatively. We published our clinical outcomes in athletes and non-athletes last year. All the patients returned to their previous work and sport with a good satisfaction score, with less than 5% failures. So in summary, with AC joints, early surgery is very, very, very rarely indicated. Treat the patient, not the grade. Reassess at 3 weeks and 3 months. Okay, I like to call them either copers or non-copers. And a rigid surgical fixation like anything else, reconstructing all the stabilizing structures. It's not just about the coracotrabecular ligaments, it's about the AC ligaments and the deltotrapezial fascia, which are all very important stabilizers of the AC joint. That's a very, very potted AC joint talk. Any question about AC joint? Yeah. Yeah. AC, absolutely. So, well, for the majority of ones, we repair the AC ligaments because the AC ligaments are there, but they're torn or stretched, and then repair and plicate the deltotrapezial fascia. If it's revision surgery and they've got a very poor AC joint ligaments, then I'll take the ligament over the clavicle, drill it through the acromion, back into the coracoid again, and then use a reverse CA ligament transfer to add a biological fixation for the AC joint, and then also take a strip of the aponeurosis. You asked now, hey? Take a strip of the aponeurosis from the coracoid and flip that up and attach that to the clavicle. So you see, then okay. I'll show. I can get a picture for you. Yeah. But essentially, the key thing is you have to reconstruct. Whatever you do, you have to repair or reconstruct all the stabilizing structures, and you have to do it in 3 dimensions. So a lot of the techniques only work off, because we've always worked off AP X-rays, so they only reduce it in one plane, and that's why they're.
But if you're doing that for 3 months,
yeah.
Some of the legs not repair themselves.
No, I mean they'll be stretched, there'll be scar tissue. I mean, so good point. So if you sometimes, what I'll look at a very acute one, which you might see, very acute ones, and you can reduce them easily clinically. They're very good. Strap them, reduce them, strap them, and keep them held. I've managed a number like that. It's very rare that I see them like that, but actually if they're reducible, then amazingly it then can all heal up and be okay. So that's something for you guys to do. If you can reduce it acutely and get it like that, strap it and support it for a couple of weeks. They heal very quickly. You're right. Yeah?
Physio, so I was wondering, you're saying rehab, but is there any sort of
loads. Probably best talk later. I mean, that's huge. Yeah, scapula, 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 scapula. Yeah.
You talk about the risk of surgery, but what's the risk of not operating on these patients in three different groups? The sedentary,
Yeah.
the upper limb athlete, and the lower limb athlete. You
Yeah.
just leave it and just don't get on with it.
Well, that's the whole point, exactly. Because what we know, we don't know very much because there's no published studies, or there's very little on non-operative, and what there is on non-operative is not very good. So, yeah, so what we know is for an overhead athlete, there's a very good study done on US Naval cadets, and that shows for high demand overhead ones in that group, they don't do as well. But it's not that they do terribly, but at 1 year they don't do as well. So they've showed that 60% have continued problems at a year in that group. So for your non-athlete, there's nothing, in my opinion, and with our results, you leave it until they demand it. Okay? For an athlete, it all depends on how it's going to affect their career, where they are in the season, if they can get back. If you find at 3 weeks they're not getting back, they're not coping, it's better to operate and go ahead and then limit their time off. You see what I'm saying? Because you have that uncertainty in where they're going to go at 3 months and how that will affect. So you'd certainly veer more, discuss surgery with them at that stage. Again, you might get some athletes that at 3 weeks they're actually progressing fairly well, but they're not 100% there and you're unsure. Then it's their decision. You have a discussion with them, and you'll see there's no, I'll worry about the answer. Then you get the ones that are really, really struggling. So then you get the ones that are doing really well. They're back, they're doing contact, they're tackling, fine, don't worry, let them go back. Sometimes they'll niggle through the season, but they'll get through the season and you can operate at the end of the season. Shall I do one last one? Should we leave?
I think we better.
We'll leave that last one. So I think we've got the two main common topics. Thank you very much.